When a head and neck surgeon looks at your neck, they aren't seeing what we see. It's not about the skin or, the muscles.
Not at all.
It's a minefield, a tightly packed corridor where being off by a millimeter. Well, it's not just about a scar. It's the difference between a patient speaking or swallowing or even lifting their arm again.
It is some of the most high-stakes real estate in the body. And the only thing that makes it manageable, the thing that makes it operable, is that it isn't random, it's a map.
And that is exactly our mission for this deep dive. We're taking these incredibly detailed medical lectures from Dr. Mashmi Tantz, and we are going to unpack the deep lymphatic system. We're going to walk through the 7 specific levels surgeons use to track these invisible enemies, like cancer, and we're going to figure out why the tongue is just this chaotic outlier in an otherwise organized system.
The tongue is fascinating. It refuses to follow the rules that govern everything else around it.
Yeah.
But before we get to the chaos, we have to understand the order. And Dr. Dess makes a really sharp distinction right from the start. It's between the superficial system and the deep system.
And that's not just about depth, right? We're talking about surgical consequence. The superficial system, that's for the skin, it's right there in the subcutaneous tissue.
Correct. And the clinical point here is it's straightforward, but it's brutal. If a malignancy starts in that superficial system, it doesn't just sit in the node. It invades the skin itself.
So you can't just pluck out the node.
No. Surgically, you're looking at a skin resection. You have to take the covering, the skin with it to get clear margins.
Which is a whole different beast, cosmetically and functionally. But the deep system, that's our focus today. That's the elegant.
It's the superhighway. It hugs the internal jugular vein, the carotid artery, all the big nerves.
And this is where the levels come in, this standardized map.
It saves lives. I mean, before this, describing a tumor's location was so subjective. Now, a surgeon in Tokyo can tell a surgeon in New York exactly where the disease has spread using these 7 districts.
Okay, so let's drive this highway. We'll start at the top. Level 1, right under the chin and the jaw.
Level 1. And even right here, the anatomy dictates the strategy. We split it into 1A and 1B.
And the divider is the anterior belly of the digastric muscle. So 1A is that little central triangle right under the point of the chin, the submental triangle.
Yes, and clinically, you need to think of 1A as the catch basin for anything in the dead center. The anterior floor of the mouth, the lower lip, the underside of the tongue.
So a lesion on the lower lip, you check 1A first.
It's your first checkpoint. Whereas level 1B, the submandibular channel off to the side, that handles a much broader load.
The sides of the tongue, the cheek.
The buccal cavity, right, and the rest of the floor of the mouth. This is why mass in the submandibular gland area is so often the first sign of a cancer on the side of the tongue. It just follows the flow right into 1B.
And then the posterior belly of that same digastric muscle, that's the gatekeeper, isn't it? It separates level 1 from the next big zone.
Once you cross that, you're on the main thoroughfare. You're entering the jugular chain. You're in level 2.
This feels like the most complex region in the whole overview. It runs from the base of the skull all the way down to the hyoid bone, but the key landmark here isn't a bone, it's a nerve.
The spinal accessory nerve. This is everything. In the operating room, finding this nerve is paramount. It powers the trapezius muscle.
The shrugging muscle.
Right. If you damage it, your patient can't shrug their shoulder. They can't lift their arm above their head. It's a massive quality of life issue.
And that nerve splits level 2 into 2A and 2B.
It does. Level 2A is anterior to the nerve, sort of in front of it. Level 2B is posterior or dorsal to it.
This is where we hear about that specific anatomical spot, the Suarez triangle.
The Suarez triangle is level 2B. It's named for the Argentinian surgeon Osvaldo Suarez, a pioneer in what's called functional neck dissection.
Taking the cancer but sparing the function.
Exactly. The triangle is tucked way up high, behind the sternocleidomastoid muscle.
So why is the distinction 2A versus 2B so vital?
It's all about the flow of metastasis. Cancers from the mouth or the throat, they usually hit level 2A first. It's like the front door.
Okay.
Now, if you find cancer there, if 2A is clinically positive, the protocol often says you must dissect level 2B as well. You have to go to the Suarez triangle.
Because if it's in the front room, it's probably already leaked into the back room.
Precisely. You can't just leave 2B behind if 2A is hot. It's a package deal to ensure clearance. Even though, digging around in 2B puts that spinal accessory nerve at higher risk, it's a constant trade-off.
Okay, moving down the chain. Level 3 and level 4. Geographically, these seem a bit simpler. Middle jugular than lower jugular.
Structurally, yes. They're discontinuing that drainage line down the neck. Hyoid to cricoid for level 3, cricoid to clavicle for level 4. But level 4 contains one of the most famous red flags in all of medicine.
You're talking about Virchow's node?
I am.
This is one of those things that it blows your mind. You find a swollen lymph node in the neck, specifically on the left side, right above the collarbone, and it's not telling you about throat cancer, it's screaming about the stomach.
It really confuses people at first. Why would a stomach tumor show up in the left side of the neck? And the answer is just plumbing. It's the thoracic duct.
The main drain pipe for the entire lower body.
Right. It collects all the lymph from your abdomen, your legs, everything. It travels up through your chest, and then it arches over to dump into your venous system right at the junction of the left internal jugular and subclavian veins.
Which is located exactly in the left level 4.
Exactly. So a cancer cell from the stomach can just hitch a ride all the way up the thoracic duct and get caught in that very last filter Virchow's node right before it enters the lip.
Wow, so we call it the signal node.
It's a Troisier sign, yes.
Yeah.
It's a metastatic alert from a totally different body cavity. The body's telling you the problem isn't local anymore. It's systemic.
It instantly changes the diagnosis from neck mass to stage 4 abdominal cancer.
It shifts the entire treatment plan. Absolutely.
Let's pivot to the back of the neck. Level 5, the posterior triangle. This is the big space between the sternocleidomastoid muscle and the trapezius.
This is kind of the watershed area for the back of the scalp in the nasopharynx. We divide it into 5A and 5B at the level of the cricoid cartilage. Surgeons really focus on this level for things like nasopharyngeal cancers or skin cancers in the back of the neck.
It seems a bit safer back there. But then we swing back to the center for level 6, the anterior compartment. And if level 2 is complex, this feels like the real danger zone.
Oh, level 6 is treacherous. This is the visceral compartment. It's between the carotid arteries, and it holds the thyroid gland, the larynx, the trachea, the esophagus, all the machinery.
And the lymph nodes here, like the Delphian nodes, are just packed in so tightly.
They are. But the real peril in level 6 isn't just taking out the nodes. It's what you might accidentally take out with them.
The parathyroid glands.
The parathyroids. These tiny rice grain-sized glands that control your body's calcium. And the cruel trick of anatomy is that they look almost exactly like lymph nodes. Or little bits of fat.
So a surgeon is in there trying to clear out all the metastatic nodes, and it's incredibly easy to just scoop out a parathyroid by mistake.
It happens. And if you remove them, or even just damage their blood supply, the patient's calcium levels crash. They get postoperative hypocalcemia.
Which causes muscle spasms, cardiac problems.
Etany, yes. It's a lifelong complication. And that's not the only tripwire in there.
The recurrent laryngeal nerve.
The nerve that controls your voice box. It runs in the groove right between the trachea and the esophagus, exactly where these lymph nodes love to hide. You damage that nerve.
And the patient wakes up with a paralyzed vocal cord. hoarse, breathy.
And they can aspirate. They can have trouble swallowing liquids without choking, so in level 6, you're fighting for their voice and their blood chemistry while trying to get the cancer out. It demands extreme precision.
And finally, we just dip down into level 7, the superior mediastinum.
At this point, you're really leaving the neck and entering the chest. These nodes are below the top of the sternum. They drain the lower trachea and esophagus. If cancer is down to level 7, that's a sign of significant spread towards the thorax.
Okay, so that's the map, levels 1 through 7. A nice, organized, standardized lattice. But now we have to talk about the tongue.
The wrench in the gears. The tongue is a law unto itself.
Dr. Das calls its lymphatic drainage extremely difficult, but clinically vital. Why? What makes the tongue such a rebel?
There are a couple of reasons. First, embryologically, it's this weird fusion of different parts, so its internal plumbing is messy. But the big thing is, it breaks a cardinal rule of anatomy.
Which is?
Usually lymphatics travel with veins. They're travel buddies. You can follow the vein to find the lymphatic channel.
But not in the tongue.
No, in the tongue, the lymphatics they forge their own path. They're totally independent of the blood vessels, which makes predicting their course much, much harder.
And Dr. Dace breaks this chaos into 4 sets: apical, marginal, central, and dorsal. So the apical set, that's the tip of the tongue.
The tip is incredibly rich with lymphatics. It drains to level 1A and 1B, which makes sense. But here's the rogue part. Some vessels from the tip will skip level 1 completely and dive straight down to the deep jugular nodes in level 3 or 4.
It's taking the express train, skipping all the local stops.
Exactly. We call it skip metastasis. It's why a tiny cancer on the very tip of the tongue can certainly show up as a big metastatic node way down in the middle of the neck.
That's terrifying. Then you have the marginal set on the sides, which is more predictable, but the central and the dorsal sets, the middle and back of the tongue, that's where the real surgical nightmare begins.
It is, and it comes down to a concept called decussation.
Fancy word for crossing over.
Right. If you look at the tongue, there's a line down the middle, a fibrous septum. You think that would act as a wall, right? Left stays left, right stays right.
That would be the logical way to build it.
But biology is messy. In the tongue, especially in the back, the lymphatic vessels just pierce right through that septum. They cross over to the other side with no problem.
So a tumor on the left rear side of my tongue. The cancer cells can easily travel to the lymph nodes on the right side of my neck.
They often do. It's called bilateral spread.
And for a surgeon, what does that mean? You can't just operate on the side with the tumor.
You can't. If the tumor involves the tip or the posterior part of the tongue, the risk of bilateral spread is so high, you have to treat both sides of the neck. You have to assume the enemy's already crossed the bridge.
It literally doubles the surgery, the trauma, the complexity.
It does. It's why tongue cancer is treated so aggressively. You aren't just chasing a lump, you're chasing this network that's designed to go everywhere.
There was one specific node mentioned, the principal node of the tongue.
The jugulogastric node, yes. It's located right where the common carotid artery splits. It's the sentinel. It's usually the very first one to light up with a tongue cancer. You see an enlarged node there, your first thought has to be the tongue.
It's incredible. The more we do this, the neck seems less like a body part and more like a logic puzzle.
That's a great way to put it.
We've gone from the chin in level 1A, through the nerve risks in the Suarez triangle, we've dodged the parathyroids in the danger zone of level 6, and now we've traced this crossover nightmare of the tongue.
It's a lot of anatomy, but it all serves a purpose.
And that's what I want to end on. Why does this granularity matter to someone who isn't holding a scalpel?
Because it shows you how sophisticated modern medicine has become. We used to treat neck cancer as just one thing. Now we treat specific pathways. We know that preserving that spinal accessory nerve is crucial for a patient's job, for their life. We know that checking the left level 4 can find a stomach cancer that would have otherwise been missed.
It's the move from brute force to precision.
Exactly. And it really highlights that the body is one connected story. The lymph nodes are the storytellers. They tell you where the disease has been, and they tell you where it's going next.
And that image of Virchow's node, it just sticks with me. This idea that the body has these distress signals, a flare going up in the neck because the stomach is in trouble.
It's profound. We tend to think of ourselves in compartments. My knee hurts, my throat hurts. But the lymphatic system proves we're just one continuous fluid loop.
Which leaves us with a final thought to walk away with. If a lump in the neck can actually be a sentence spoken by the stomach, what other signals are our bodies broadcasting right now that we're just misinterpreting as local noise?
How many other maps are hidden right under the skin that we just haven't learned how to read yet?
The body is always talking. We're just getting better at learning the language. Thanks for guiding us through this today.
It was a pleasure to explore the map.
And thank you for diving deep with us. Until next time, keep listening.